Everybody, I'm Reinhard, CEO of Phagenesis. I tell you how we can reduce lengths of stay in the ICU by treating dysphagia. Also, just clearly what we're asking for, we're just closing a 35 million round in order to scale our European and US commercialization. We have already MDR, CE mark, and FDA approval, and we have a huge TAM. So before I go on my presentation, though, let me get you on a journey quickly. Imagine you're in a room, and the door is closed, and with a key. And now 1 day, 2 days, you're desperate. You wonder, how do I get out of this room? How do I, this breathing tube in my mouth, it's hurting me. I'm feeling like drowning. 3 days, 4 days. How can I get out of this room? I'm becoming really desperate. Well, hang on. Is there a key? Is there a key to get me out of the room? Why have I not seen this key before? I'll tell you now what Phagenesis is the key. Phagenesis is the key to get you out of the room no patient wants to be in, which is the ICU. I tell you how we get you out of this room 4 days or more earlier. So bear with me. So we get you out of the room earlier. Is of course, ICU is a scarce resource. So getting you out means reducing lengths of stay, freeing up bed, saving a lot of dollars to the hospital. And each day in an American hospital each day in the ICU costs about $6,000. So what do? We treat dysphagia. And dysphagia means patients can't swallow. They can't even manage their own secretions. And that's associated with the fact that we can't actually extubate them successfully. We can't decannulate them. And hence also we have a high risk of readmissions because they keep aspirating their own secretions. What we can do is, in the ICU, we can treat the dysphagia. We can treat that swallowing issue, which can't be done in the current care setup. It can't be, because normal swallowing treatment actually means that patients are over weeks or months trained on regaining swallowing control. We can do that because our new stimulation device can be applied in the ICU directly. Yes, we've done our homework and are ready now to ramp up commercially. Why? Because we have a lot of compelling clinical data over 25 years, over 800 patients under study conditions, a lot of RCTs, over 3,000 patients already treated commercially in Europe. As we now come to the US, because we have CE mark in Europe, we have just received FDA approval in the United States in September. Now we're going to go to commercial. We're under the Novo pathway, which we have successfully completed. We have proven in our studies that we can successfully reduce lengths of stay in the ICU. And because we are a breakthrough device, we have also the entitlement to NTAP, New Technology Add-on Payment, which means from October onwards in the United States, 2/3 of the device costs will be reimbursed by CMS. And we own our space. So this is the first time ever new stimulation can be applied for dysphagia. We have invented this technology. It's the first of its kind. We have a strong IP portfolio. And while we are a European company, we have already a very strong team in the United States. So what's happening? Why do patients forget how to swallow? The major problem is because the sensory swallowing loop is being disrupted. And that could be a central disruption due to a brain damage like a stroke. It can be a peripheral disruption caused by the pure presence of the breathing tube. And actually means a continuous painful irritation of the pharynx back of the throat, which actually then makes the brain switch off the sensory input. So that loop is interrupted in order to actually trigger swallowing successfully. The worst patients are actually those where central plus peripheral disruption is happening. And that's where we have the strongest data to show how successful we are. So we can kickstart that sensory loop with an electrical super bolus. That's how you have to have it in mind, the electrical super bolus to kickstart the system. So how does it work in practice? We put a catheter with electrodes, catheters in the nose with electrodes touching the pharynx, the back of your throat, and then with the tip of the catheter going into the stomach, because we can use the same catheter not only for stimulation, but also for feeding. That catheter is connected to a base station, which is the stimulator box, basically, and with that we can trigger the strong stimulation, the super bolus, I've described it before. So 3 to 6 days of stimulation, not more, so we can retrain the brain in 3 days. And it's just 10 minutes of stimulation per day, so really straightforward and easy to implement. Also important, it's a temporary therapy. As I said, we kickstart the system. There's no implant required, no surgery, no patient involvement required. And that's one of the key elements why we can successfully apply it in the ICU, because patients don't need to collaborate, and it can be done really, really quickly and easily. And it's a safe therapy. Of all these 3,000 patients commercially or 800 patients under study conditions, zero serious adverse events. So it's a really safe therapy, easy to implement. It has a big clinical application. So dysphagia is associated with stroke. Every second stroke patients can't swallow, but also with patients, as I tried to describe before, who have actually been exposed to a breathing tube, so have been mechanically ventilated. Actually, the beachhead for us, as we now go into the US, is the intersection, so mechanical ventilated stroke patients, because it's a fantastic business model, because we can show such an important health economic as well as clinical benefit. But also there's other groups of patients, like the ones with persistent dysphagia, who fall out of the healthcare system, still with severe dysphagia, still can't actually swallow, means they can't eat probably for the rest of their life, need to be fed directly into the stomach with a tube, or might still be on a tract cannula because they could never be decannulated because of dysphagia, might not be able to eat, might not be able to speak the rest of their life. It's very profitable, so I told you it's a big TAM because dysphagia is associated to many complications and associated to many indications. We have a clear revenue model per patient. 4,500 is our average selling price and revenue per patient, and we are highly profitable in terms of margin. This slide is, without trying to go to all the details, just trying to give you a feeling about the exposure here. So patients who have been tracheotomized have a 70% risk of having developed severe dysphagia and can't be decannulated right away. So that's why it's normally a very cumbersome journey to actually decannulate the patient. Still, if patients are orally intubated, 20 to 40% of these stroke patients can't be successfully extubated, needs to be reintubated and probably are then tracheotomized. And again, dysphagia is the reason. So this is a huge thing. Why has it not been on the radar eventually of you? Because it can't be solved so far. There was no solution. So why bother? It was a complication which was managed but couldn't be sorted out in the ICU. So what we have shown in our studies, and that's just a few data points from the studies, is that by applying our therapy, we can reduce lengths of stay. For example, the stroke patients by 13 days. That was a Lancet study we have published in RCT. Or in the recent study, 7 to 13 days for these extubated patients. So it's immense impact of the healthcare system. So let me summarize. So we improve outcome by reducing risk of extubation failure, accelerating decannulation, reducing complication, because we can treat dysphagia in the ICU. We reduce hence lengths of stay in critical care, save costs, and of course free up bed capacity. And we're the first and only treatment of dysphagia which can be applied successfully in the ICU. We're a great team, so I will say there's really black belts who know commercialization from some of the big guys here. So we have done it before and are really keen to now successfully implement it in the United States. As I said, summing up, we are ramping up commercialization. We are closing around right now. We are looking for strategic partners, having good conversation in this regard already. We believe we're in a dual track trade sale IPO for the next 2 to 3 years. And I close it here with, again, going back to my key. I hope you have understood now why we as Phagenesis have the key to get you out of the room, get the patient out of the room nobody want to be in, which is the ICU, sooner. Thank you for your attention.